Boy, the way Glenn Miller played
songs that made the hit parade.
Guys like me, we had it made. Those were the days. Didn't need no welfare state.
Everybody pulled his weight.
GRO was sour and great. Those were the days.
And you knew where you were.
Girls were girls and men were men. Mister, we could use a man like David Hoover again. People seem to be content. $50 paid the rent. Freaks were in a circus tent. Those were the days.
Take a little Sunday spin.
Gotta watch the Dodgers win.
Have yourself a dandy day
That cost you under a fin.
Hair was short and skirts were long. Kate Smith really sold a song.
I don't know just what went wrong. Those were the days.
That's a measure of how good one is if the Tony stays awake. 100%. Okay. How's that? Much better. Okay. We'll go ahead and get started. I'm Dr. Denise Minor-Williams. I am the Special Geriatrics Research Fellow. That's the official title of it. I like to stress the special part for the VA out of rec. And this morning I'd like to talk with you about the palliative care family meetings. This will be, we will cover two things. One, we'll go over in general about family meetings. So it's sort of family meetings 101 here. And then I will go over the results of a study that I undertook last year. We'll go through the who, what, when, where, and how approach for family meetings. First of all, before we get started though, has anyone ever been involved in a family meeting? Okay, have you conducted it yourself, or, okay. Do you do this routinely? And where do you work?
One, medicine, but especially in intensive care units.
Intensive care.
Yeah,
Okay.
often if you're on the ward.
Okay. Okay. We'll go into that a little bit. Okay. So the what of the family meeting then is a method of facilitating communication between the patient, the family, or among the patient, family, and care providers, so that you're all on the same sheet of music. And it's especially useful in palliative care because we're setting goals a lot in what we want to do with in the palliative care. Usually they're held within palliative care and ICUs. The literature is most in those venues. However, they can be appropriate, very appropriate in any chronic or complicated illness setting. And I think that's probably where we need to push the issue in geriatrics, that we could probably be using family meetings a lot more than we probably are. Why do we have family meetings? We do it, there are several reasons. It can be to clarify the diagnosis or prognosis of the patient. Sharing information between the family and the patient and the care providers. Clarifying the goals of care. That's particularly important in palliative care. But it's important in any chronic and serious illness too. Where are we going with this? What do we want to do? And in palliative care meetings, we get into what are your values, down to theirs, because we're talking more about end of life then and the type of care. But at any point, talking values and goals is important. Can be important with the family. And then it's determining the plan of care. And this is where you're involving the family and the patient in the decision making of the care. Especially in palliative care, this provides a great deal of comfort and support to the patient and the family. They can be held when a patient is admitted. Some of the inpatient palliative care services will routinely hold family meetings when a patient is admitted, so that, again, we've got an idea of what the plan of care is, where we're going with the patient. It can be when you're delivering, what we call the bad news, when the prognosis does not look so good, or when things are, that's when you pull everybody together to make sure that you're getting the same information out to everyone. And certainly when a plan of care is needed, so that you, as the provider, are coming up with a plan that the family and the patient are going to buy into, obviously. Okay, we have lots of ideas, but whether they're going to meet up with the family, the patient and the family is the part. The how of family meetings. You can have spontaneous family meetings, but ideally there should be some preparation, and then the conducting of the actual meeting itself. And then there needs to be the documentation and the follow-up after the meeting to really fulfill to gain the most benefit from this process. Preparing for the family meeting, preparation should include identifying who should come. And sometimes that's talking with the patient, okay, who are your important family members? We're in a community where there are many families that are very extended, but you're going to want the key players there, the decision makers, the primary family caregivers, notifying everyone involved. Backstroke for a minute, for identifying who should come. When you've got different consultants working with the patient, you need to decide who would be important to have at the family meeting. A lot of times the palliative care service, consult service is called in, and we determine that we need a meeting, and then it's really important, but a lot of times it doesn't happen, that the attending team come to the family meeting, so that we're all there together. That's very important for the family. For the patient, a lot of times with palliative care, I keep saying the family, the patient isn't there. So that's why I'm stressing family rather than the patient. But that's very important symbol, of concerted effort to coordinate care. And it makes it easier. Then everybody knows what's going on, and I'll give an instance of that later. The teams should coordinate before the meetings. Where we're going with this patient, test results or anything, so have sort of a plan on hand. Preparation of the environment is something that is ideally done, and that's finding a quiet room to get the family away, especially if it's delivering bad news. It's something as simple as having Kleenex ready, for the family if you're going to be doing that. But turning off the cell phones and the beepers during the time of the family meeting is very important, especially when you're delivering bad news and making some real heavy decisions. So that's all preparation of the environment. Okay. We just went out. That's your name and how you contribute to the patient's care. Okay? Okay, that's where we are. Clarifying the purpose of the meeting. making sure that everybody knows, and that's part of the preparation too when you're getting family members to come, so they sort of have an idea, so they can bring their ideas to the meeting with them. So you're clarifying that purpose. And then you start out with figuring out, clarifying what the patient and the family actually know about the disease, or about what's going on. And you ask them, tell me what you understand, what your diagnosis is, what's going on, everything that you know. It's if the patient is not there, is not able to attend this meeting, it's real important to, as Dr. Sanchez-Riley always says, bring the patient into the room. And that's often done figuratively, where it's all about the patient and what the patient wants, where the patient's going. So it's always from the focus of the patient, not the family members making the decision, but from the patient. So that's always prime. So then you go ahead and you address the specific objectives that you've identified and the purpose of it. If you are breaking bad news during this time, you need to, and this sounds sort of odd, but you need to ask permission. You need to sort of feel it out, and we have some news, or, you know, do you want to hear this? Most often they'll say yes, but sometimes they don't. So you just sort of, and that'll give you a good idea of where you are with working with the family. So it's very important to do that. As you're going through, periodically check with the patient and the family. Are we okay? Are we on track? Are you following? Okay? And you need to do that because sometimes people, you know, there's a power differential where sometimes people aren't willing to speak up if they don't understand something. And until you give them permission to say, you know, are you okay? What do you think? They're not going to say it. All right. Use whatever, you know, resources you have. If you have handouts, drawing pictures, of course, whatever you need. Don't be afraid of silence, especially if you are covering something that's very difficult. I mean, if you're giving a very difficult diagnosis or prognosis, silence is okay. And we as a culture aren't very comfortable with silence, I think, as a whole. You know, we start tapping our fingers and start talking, jittering talk, not always meaningful talk. But it's okay. Sometimes it's even appropriate to break for a minute and just say, okay, why don't we just hold off for a few minutes so we can think about this and meet back here in a couple minutes. Now, that's in the ideal world, and I know there's always a time element with this, but don't forget about that technique, because sometimes, especially when it's a meeting where you're trying to decide the plan of care, the family wants to talk about it without you sitting there. So it's appropriate to say, okay, well, you know, let me just go take this call or do something, and I'll be back in a few minutes. Give you a few minutes to talk about this or whatever you want to do. Okay, so that's not inappropriate too. There's one study that was interesting out of critical care medicine that was able to identify 3 types of statements that clinicians make that provide a great deal of satisfaction or increased satisfaction with the families. And that's assuring that the patient will never be abandoned before death. Okay, these are palliative care meetings. It's assuring that the patient will be comfortable and will not suffer. And this needs to, we may think that, I mean, we know we do that, but this needs to be articulated to the families and the patient. And then also that you will support the family's decision, even if that decision is counter to what you think would be the best thing to do. And that can be very difficult sometimes. But the family needs to know that you're going to support them when they make the decision. And then you conclude the meeting. You're going to want to summarize all the decisions that were made, the areas of consensus, the areas of disagreements, the decisions and the ongoing plan. If there are specific things that need to be done, who is going to be responsible for doing what. You want to emphasize the positive outcomes, even if you couldn't come up with a plan. Even if, you know, you've got family members who are battling each other. It's you know, we've made a good step here with at least coming along and talking about this. And maybe the only plan you have is to meet again, you know. That may be the best you can do, but that's a plan. Offer then the final opportunity for questions and concerns. Even though you think that everything may be covered, it's just, okay, anything else? And to go over that. And then thank everyone for attending. Sometimes this is very difficult. And one thing that Dr. Sanchez-Riley always does is to tell the family what an honor it is to be caring for the patient. And the impact of that is immeasurable on the family and the patient. When you're able to very sincerely say that, and if that's how you feel, to be able to articulate that, because that did come out in the study that we're going to go through in a minute. So think of it. So that could be part of the planning for you of holding the family meetings, of how you conclude them. That can be, we have to realize that in serious illness and in death situations, especially if it's nearing death, how the healthcare providers treat the family is going to be remembered for the rest of their lives. It's going to be that big of an impact. So that's very important. It needs to be documented. Who attended, what was decided, what's the plan of care, you know, everything that happened, and what's the plan of care and everything that goes on. The follow-up is, and actually that should have been a separate one because that's really important, is if there is anybody on the team who is not there and needs to be notified of some plan of care decisions, especially if it's a change in plan of care, that they need to be notified right away. Follow-up also means with the family, if it's at all possible, that one of the team members afterwards ideally should go back to the family and ask them how it went with the family meeting. This is extremely important to the family and the patient. And if that can't be done on every occasion, then certainly on the occasions with the family meetings where some very momentous decisions were made. That needs to be followed up. We'll just leave it with that. Okay, part 2. This was a study that I undertook last year in conjunction with Sandra's study of exploring caregiver outcomes and participation with geriatric palliative care consult service. So my study was tagged onto that, and what I was looking at was the caregiver perceptions of the family meeting. I wanted to describe the content, what happened, and the effectiveness of these family meetings from the composite perspective of the caregiver, the family caregiver, the palliative care team member, and the notes from an observer. So I was the observer at these meetings, sitting and watching these meetings and watching the interactions and then doing the interviews afterwards. It's a qualitative description study with 12 semi-structured interviews, plus the field notes that I took from 6 different family meetings. Qualitative, the analysis was done with qualitative description using grounded theory techniques, which employs a constant comparison such that as soon as you've collected data, which are the interviews and the transcriptions of the interviews, you're looking at that data and analyzing immediately before you go on to the next interview. So then at the next interview, you're sort of keeping in mind and comparing what was going on previously. This is real important because in this type of research, then when you're doing these semi-structured interviews, then you can start validating some of the information from prior interviews with such questions as, well, you know, some people think this about this topic. What do you think about that? Does that resonate with you? And then you can get more information and validation of concepts as they arise. From this, the Rashomon effect is the convergence of different perspectives into one understanding. From this, 6 themes emerged from these meetings, and we'll go through each theme. The first one was the soft touch, and this was primarily from the perspective of the family caregiver. What this involves is the manner in which the team presents themselves and how they present some very difficult information. And how they listened to the patient and the family throughout the meeting. So it's the way you do it, because some of this is really hard stuff. You know, the delivering bad news, nobody likes to do that, because you know people are going to hurt when you do it. But it's the way you do it, and the kindness, the approach, and that is very impacting upon the caregiver. The second theme that emerged was came from both the caregiver and the team member, is telling the way it is. The caregiver liked it. There's the straightforward approach of telling it the way it is, you know. And the team members would most often talk about getting on the same page, so they could be assured that we all understood what each other were talking about. And so this is both the information and the way it's presented. So it's clarifying the situation. Coming up with the plan was something that was constantly talked about with the team member leading the meeting. This is the measure of success for a meeting. And again, the plan can be specifics about the patient care, or it can simply be, we still disagree and we need to meet again. That's still a plan. But having a plan is better than people getting up and walking out and not coming together at the end. Okay, so that is a measure of success with the meetings. Follow through was an important element with the meetings. This was from both the family caregiver and from the observer notes. This is particularly, well, from 2 perspectives actually. This was following through with other members of the healthcare team who were not at the meeting and clarifying the information to make sure that we're on the same plan of care. And that became, the importance of that was demonstrated in one occasion where the family decided that they were not going to take any more life-extending therapies. So they were not going to do the antibiotics anymore. You know, we're winding down, and we're clearly getting into palliative or care, or comfort measures. The attending team did not attend the family meeting. And later on that afternoon, the attending team came and said, well, we need to draw blood for this, and we've got to get this started. And the family, the patient was not talking at that time, was not with us, and the family was very confused. I mean, it was devastating, really. So, which emphasized again the importance of quickly communicating, especially plans like that, to the attending team. The second part was with the caregivers in just that element of following through and following up with them. Did you understand everything at the meeting? And it's an expression of concern. And you know, from that study that I talked about with the clinician saying, we're not going to abandon you, we're not going to abandon the patient. This is part of it. It's going back and just saying, did you get everything? We're here with you. I know it's a real difficult time. What didn't you understand? Is there anything I can clarify? Sometimes it was interesting, and the family, there was one instance where the team understood one thing and the family member had not been decided about it as far as the plan of care. And the team went away with, oh yes, this is the family's the plan of care. But going back, and this was just for the interview for this study, so, but it was fulfilling the purpose of a follow-up for the family meeting, because I was there at the meeting. So it was actually a combination of therapeutic and research at that point. But so it was only going through that because I was there at the meeting and then I was there with the follow-up at the interview, they were able to clarify what was said and definitively decide, okay, well, I'll go ahead and do it. It's like, oh, I thought we already decided that, you know? So that's, again, you know, a good example of why you need that follow-up, especially with the meetings where important decisions are made. Thanks for listening, and that's the comfort aspect of going back, of allowing the patients, not of going back, of allowing the patients and the families to give voice at these meetings. Yeah, this is follow-up. Okay, one of the quotes from this was, once again, and this was from the notes, the field notes. Once again, the caregiver thanked me, which she did repeatedly, for being able to talk at this follow-up interview that I had. It seemed as if this opportunity to talk when all I did was listen was very important to her. She needed that time. It, you know, is processing the very difficult information that she was going through. There was evidence of internalization of some of the difficult material that was present, that was given at the family meetings. And this was in regards to, specifically, it was the end-of-life communication and how to talk with the family members. So what we gained then from a study like this and looking at these themes that emerge are understanding that, you know, palliative care, and again, these were strictly palliative care family meetings, some of the goals of palliative care are providing comfort and symptom management, of promoting communication, facilitating communication among patient, family, and caregivers, healthcare providers, and providing family support. And the family meeting is a wonderful opportunity and an important tool for being able to do this. Yes, it is somewhat time consuming, but the benefits that you derive from it, of being assured that you're on the right plan of care, of giving the comfort to the patient and the families, are certainly well worth the time that it takes to invest in this process. The family meetings sometimes become a venue for the family being able to talk and to being able to discuss with each other. And that truly is an honor to be a witness to this type of meeting, where the patient can say, well, you know, to his wife, we've had a good life, but it's okay for me to go now. Sometimes people can't always talk like that openly with each other, and sometimes, and so these are the occurrences that happen that are very important and bring the real humanness of what we do home. Caregivers describe the family meeting then, it's as important for closure and for peace of mind. And the peace of mind referring to making sure that, you know, you're bringing everybody together and you're all able to decide together that it's okay of what your decision is. For one participant, she had decided to withdraw life-sustaining equipment, but she felt that there was a resistance with the rest of the family, with her husband's siblings and everyone. So bringing it together, having us talk with everyone and describe what was going on, validated her decision, and then she knew it was okay with the family. So that gave her some peace of mind of bringing consensus. Talked a little bit about encouraging end-of-life communication, and that can be very important in the palliative care family meetings, or, you know, in ICU meetings too. The patient is still able to talk. A lot of people don't know how to talk, what to say when someone is dying. And it's really important to have a facility or a comfort level, for you to have a comfort level of talking with them on how to do it. And usually go with Ira Byrik's recommendations of talking with the family about forgiveness. Well, sometimes it's easiest to start with gratitude. of saying thank you for who you are and what you mean to me, of talking about forgiveness, of saying please forgive me for anything, you know, fill in the blank. I forgive you for clarifying, being able to speak openly about loving me. Some people can't do that. They haven't done that. And they need to be able to, and part of this is telling them to articulate what they think they already know. It's important to hear the words. And so going through and working with the patient and the family when it's appropriate can be a very important part of the family meeting. The implications are that although family meetings should definitely include clear identification of the team members and their roles, how they're contributing to the patient care. It needs to give voice, so it's all about the family and the patient and where they want to go based on their values. Families can assist the family meetings can assist the family with end-of-life communication when that's appropriate. The palliative care providers, it's real important that you be very clear and very kind when you're delivering bad news, such that you can do it without giving any false hope. And the title of this presentation came from this quotation from this one family care member, where a family member, where she said, "I like the manner that they went into it, slowly. I like that each person explained what they do. I like the explanation, and this was that the caregiver was being asked permission to implement the patient's decision, not the decision herself, and not make the decision herself, because that was at a point where the patient wasn't there, and she had to decide. And we said, no, it's not your decision. It's what would your husband have wanted. We only implement his decision, and you give us permission to do that at this point in time." And just explaining that to her was a great relief for her. And she said there was no false hope. It was, they were like an iron fist and a kid glove, giving the hard news, but in a manner that you can handle it. And then again, we talked about the follow-up after the meetings. So the conclusion could be that family meetings do require a level of skill in planning and properly implementing them. They're often very rewarding. That it's an immeasurable aspect of it. They increase satisfaction, certainly of the patient and the family, and very probably could be the healthcare provider too. The satisfaction of knowing that it'll probably make it easier in implementing what their plan. And it certainly can be a very powerful and important tool in patient care. So do we have any questions? Comments?
When you talk about who should participate, it's been my experience that, especially in our veterans population, sometimes the lines of relationship are not always clear. In other words, sometimes people have more than one family. Right. They have stepchildren who may actually be the spokesperson, or an ex-wife. It's not unusual for ex-wives to come forward. So, sometimes you can have, 2 to 3 people in the room who are actually significant, consider themselves the identified patient significant other. So, whenever I get ready to do one of these, I make a fair amount of effort to try to find everybody that might be involved in making decisions about whether or not how to care issue. And frequently, the other thing that happens is that you think you communicated with the person who's going to make the decisions, and then it turns out that there's a whole other group of people over there that are making the decisions.
Yeah.
So try to identify that.
That can be very challenging. That's a good point. Thank you for clarifying that. With deciding who should be at the meeting, and there's the legal way of deciding. There's a fallback legal plan if there isn't an advance directive in place that has that clearly identified. But really, consensus is still among the family members is very important.
And I think that there's some resistance from some people. They think that all this HIPAA stuff, you know, we can't call people because we don't have the permission and all that. You know, I think sometimes we've really hurt the patient by trying to respect their privacy maybe too much. You know, I'm not saying that we should blatantly violate HIPAA rules or anything. We need to be a little bit more aggressive about identifying decision makers on patients.
Interesting point. Yeah. Yes.
In the training place like this, what do you think is the best way to bridge like the team handling the situation that's going to be a little longer than those people, the team, you know, attending trainings? And it's going to continue going on when the next month is a totally different group. Does that happen, or how do you bridge that?
In terms of the plan for the patient care, or?
In terms of like the faces they see, or who's managing or guiding the situation?
Just being very, very clear with that needs to be clearly identified for all persons. So going into the families, I am here for this month. I am going to be the person. I know, but it's true. I'm going to be taking care of you, and I'll direct all your questions to me. Here is my name. And that will do. It can help. I mean, you have to be honest about what the situation is.
Do you think bringing at least the attending or one of the other trainings for next month, so they at least familiarize with the face, they acknowledge that they're already being involved, know something about their situation?
I think probably. This is going a little bit beyond family meetings, but I think that the person who is leaving has the obligation to make the transition statement of, I'm leaving now, and Joe Brown will be the person that is going to be taking care of you. And if you can bring Joe Brown with you, you know, and introduce, that would be fine. But making sure that they know that you're not coming back anymore and somebody will be following up, you know. Yes.
These things come out of the study we've done during the VA.
Yes, sir.
Right. So, how would you adapt those for working out in the private sector, physicians working in the community, people who have long-term relationships with patients and families? And then how do they bill for those services?
Number one, with qualitative studies like this, the idea is that enough detailed information is given that is put out so that the people on the outside, you know, somebody picking up the study can figure out how much that applies to their own situation. Because all this study does is describe what is happening at this one point. I mean, so it's not. We're not saying that it's generalizable, other than in terms of giving enough description for the people looking at the study to decide. So they can pick the elements that are appropriate to them, knowing that they have worked in another setting to assist them with the work that they're doing. I'm not sure about the billing. And that is a very interesting question.
Well, for the billing, I guess the best way to do it is using your time code, the code per time, and they go like in increments of 30 minutes. So you code depending on how much time you spend. Now, if you spend 55 minutes, you can round it up to 60. It doesn't have to round down. It's what's closer and get more money and was billing it as a 60-minute
so it's
time
a time
code
as
opposed to a 30.
Mm-hmm.
Right. But then that's why it's very important to document in your family meeting how much time you spend, and it has to be a little detail as far as these were the issues discussed and these were the people present and this was
mm-hmm.
And you can't take the time that it takes you to write it down.
It's
time
does not count.
well, it counts. It depends. In the inpatient setting, like the time that you are talking to the patient and like within the nurses within the ward, that time counts. In the outpatient setting, if you go to people's home and you visit there, then only the face-to-face count. But when you're being time-wise, more than 50% of the time has to have been face-to-face time in counseling.
Well, actually, all the time you can only bill for face-to-face time. Right? That determines the level of service. And if you're going to go on a time-based code, you have to put a start time and a stop time, especially if you're going extended amount of time. It turns out to be like here at the VA, all the elements of the team are here, right? And they all work for the same organization, and the VA pays for that. Actually, the taxpayers pay for the VA at that. Out in the private sector, in the community, if you've got an office-based practice, you may not have all those elements there, and getting the team together, getting the family together is tough, and the amount of reimbursement for that service delivery is also doesn't make up for how much time it actually takes.
Yes. I guess one other thing with billing is that eventually people that is working in the MICU and has several patients, they sometimes put at the end of the note that the attending spent 45 minutes and probably give more than 8 hours a day. So you will be in trouble billing for more time that you really spend in the unit. But my question comes from a suggestion regarding these big Hispanic families that you meet in the room, explain the thing. Usually somebody is tough to do follow-ups because after you do the meeting, more people is coming from outside the city, and everybody wants the explanation from the very beginning. So you have to spend like extra 30 or 40 minutes with each of them. And then how do you do the follow-up? Because you cannot.
Good question.
You cannot spend that amount of time every day. And the other thing is that with the HIPAA regulation, and sometimes when the family is big, you rather pick or ask them to pick one to be the representative of the group, so you don't have to explain every day 20 persons rather than one.
That's an important part of the family meeting with when you're meeting with the family of those dynamics, and then it's clarifying who will be the spokesperson and who the care providers, the healthcare providers, will be coordinating with, and the decision maker.
Yeah, but if you have to, sometimes you don't get to a decision immediately, and you say, okay, we need to go day by day. We will meet tomorrow again. How do you manage that? Because some of them have to return to their cities, and they want eventually some information by phone.
Well, I think you're taking too much on yourself at that point. The family has to manage that. Okay. What you do is you say, I will communicate and coordinate with which one of you, which two of you. And I will do all the coordination with them, the family members, and then you tell those two people, you're that person, then you need to, I would suggest that you then transmit this information to the family, because my time is limited. I will be, we can have another, if you want to set up another meeting and just say, we'll do it in 2 days, and we'll go over what's going on, and whoever wants to come will be, can certainly be here. But clarifying that up front, of just saying, I can't, explain it to everybody 15 times. So we need a spokesperson. It's the best you can do, I think. That's something you have to play by ear too.
If you don't sit down with them and explain the whole thing.
Yeah, and that's when you get everybody together. Then you just you just make that very clear.
And that's why it's important to try to figure out what everybody is.
Right.
Because you're talking to a third of the family, then you're going to get the cost from the other 2/3.
Yeah.
And if you can cost them, you're going to get it.
Yeah. And that is part of when we're talking about the preparation for a meeting. When you know you have a family like this, it's better to take that extra time to make sure that you identify the correct people that are going to be there.
And sometimes they have to be there over the phone because they're
And that works too.
across the country.
Yeah,
but
that conference calls are good things.
Yeah.
It's
You
better
guys have
to
video
have them.
conferencing available now.
Excuse me?
Don't you have video conferencing for family meetings or? Is that
Well,
on
not
video?
typically, but they did do one this Friday. They did one where the family drove to a VA and then they pull up the equipment to the patient's room, but that was like a noise that was done. Well, I hope we can do it more.
We're doing
working
a second
on
one.
getting some equipment to
We're doing tomorrow, we're doing another one.
Oh, okay.
So it's starting that trend.
Okay. Anything else? Well, thank you very much.
Songs that made the hit parade.
Guys like me, we had it made. Those were the days. Didn't need no welfare state.
Everybody was great.
G-R-O-S-L and great. Those were the days.
And you knew where you were.
Girls were girls and men were men. Mister, we could use a man like David Hoover again. People seem to be content. $50 paid the rent. Freaks were in a circus tent. Those were the days.
Take a little Sunday spin.
Gotta watch the Dodgers win.
Have yourself a dandy day
That cost you under a fin.